Welcome everyone. It has just begun. I would like to welcome everyone to our 2025 Science Summit presentation. It is titled Harnessing Technology in Science and Innovation to Address the Global Challenge of Preventable Mortality Associated with Childhood NCDs at the United Nations 80th General Assembly.
For some housekeeping, please ensure you are muted if dialing in virtually. This event will also be recorded and posted with a report soon on the Plan and Mates for Kids websites.
We would also now like to acknowledge the traditional custodians of the lands, waters, and seas that we work and live on, and pay our respects to elders past, present, future, and emerging, and thank them for their continuing custodianship. We would also like to acknowledge and welcome all Indigenous people who may be attending today.
This event is in partnership with the Lehigh University United Nations Youth Representative Program. The Lehigh Youth Representative Program, established in 2008, matches high-achieving Lehigh students with UN-accredited NGOs. Plan is one of 13 NGOs and one of Lehigh's strongest partners. Plan currently has 2 UN Youth Representatives, my partner Tara Chalbam and myself, Samiha Islam, who advocate for CLAN at United Nations events such as this one. This program allows youth to have a voice in global matters, and in our case, advocacy for children who are living with non-communicable diseases in resource-poor settings.
The focus of the 2025 Science Summit is the pivotal role of science in addressing societal challenges within planetary boundaries to enhance global well-being. This theme underscores the necessity of scientific innovation in maintaining Earth's stability and resilience. This year's theme emphasizes the importance of conducting science responsibly, respecting Earth's natural limits, and prioritizing science for the society and the people. In this presentation, our speakers will highlight the importance of SDGs 1, no poverty, 3, good health and well-being, 10, reduced inequalities, 16, peace, justice, and strong institutions, 17, partnerships for the goals, and as usual, all the other SDGs are equally important.
Now I'd like to introduce you to CLAN. CLAN, short for Caring and Living as Neighbours, is an Australian non-governmental organization founded in 2004 by Dr. Kate Armstrong. CLAN is committed to equity for children living with chronic health conditions in resource-poor settings. CLAN's strategic framework for action focuses on multi-sectoral action on 5 pillars, which include 1, affordable access to medication and equipment. Second, education of the individuals, families, communities, health professionals, policymakers, and the international community. Optimization of medical management, including primary, secondary, and tertiary prevention with a biopsychosocial focus. Encouragement of family support networks. And lastly, by reducing the financial burdens on families that lead to poverty, we help people become financially independent, enabling them to provide the necessary health care for their children in the long term. Plan. Sorry. Our event focuses on non-communicable diseases, otherwise known as chronic diseases or NCDs. NCDs, unlike infectious diseases, are long-term or lifelong health conditions that cannot be transferred from person to person. They can be a result of factors such as environmental stressors and genetic inheritance. Some examples of NCDs you may have heard of include cancer, diabetes, sickle cell disease, and congenital adrenal hyperplasia, CAH. Many NCDs can be detected via newborn screening, which includes tests such as pulse oximetry tests and heel prick blood tests. Many NCDs are diagnosable and treatable. However, many economic and social factors can increase preventable morbidity and mortality of children living with NCDs. Therefore, our presenters seek to advocate for education and resources where NCDs leave no child behind.
And now I will be talking about at the Mates for Kids Network. It stands for Maximizing Access to Essential Supplies for Children, and it is a global coalition of organizations and individuals committed to reducing preventable mortality from childhood non-communicable diseases, NCDs, in resource-limited settings. The vision of Mates for Kids is to ensure that every child living with congenital adrenal hyperplasia, CAH, has the highest quality of life possible. The goal is to reduce preventable CAH mortality by 30% by 2030. We believe this is possible through improving access to essential medicines, strengthening CAH and childhood NCD communities, and scaling newborn screening. I would now like to introduce Dune Barucht.
Hello, everyone. I am a fourth-year student at University of North Carolina at Charlotte, double majoring in public health and health systems management. I'm passionate about addressing global health challenges and advancing in policy worldwide. Next slide, please. So one of the ways we advance this mission is through our community development grants. This year, we're offering up to three 1,000 Australian dollar grants to support initiatives in low, lower middle, and upper middle income countries. Applicants must be part of the Mates for Kids community of practice on the WHO Knowledge Action Portal. And I'd like to announce our round 6 grant recipients. Okay, so the Brazilian Association in Sao Paulo, which supports patients with adrenal insufficiency and CAH through free services, education, and advocacy. First, I'd like to introduce Haru Charlini, a patient living with adrenal insufficiency and a dedicated volunteer with ABA, who has been a strong advocate for patient education and empowerment.
Thank you, Dune. It's a pleasure to be here. And on behalf of Association ABA, the Brazilian Association, I would love to really thank for this opportunity. Denise, who co-authored, and Dr. Adriana, they would love to be here, but they unfortunately couldn't join yet. And our association, it's patient-led as well, and it supports families, children living with CAH and adrenal insufficiency, which are rare NCD diseases that often remain so invisible. And in Brazil, we have an issue because the emergency hydrocortisones, the kits, they are not commercially available, only through our nonprofit association. So information and access to them can mean the difference between life and death in an adrenal crisis. So with this grant, we'll be able to produce educational videos, redesign step-by-step instructions for the injections, deliver these emergency kits to hospitals and families that are often so vulnerable, both socially and culturally. So then with technology, we're going to use things like QR codes, so then we can expand the access in a sustainable way, even in very remote and underserved areas, because Brazil is the 5th biggest country, so we have a lot of that. So this project, it's a concrete example of how science and innovation can really advance the sustainable development goals. So then, like reducing inequalities in health, empowering families, and supporting responsible, equitable healthcare delivery. Because equity in science means equity in survival, especially for children with rare diseases. So thank you so much for helping us make this possible.
Thank you so much for speaking. Now I would like to announce our second recipient from HSC Fuerzas in Colombia, a community-led initiative providing education, advocacy, and peer support to families living with CAH. I would like to introduce Angela, a young adult living with CAH, junior leader in the community, supporting peer engagement, education, and empowerment.
Hola, Para todos, buenas tardes. Mi nombre es Angela Nicole Castro. Yo soy representante de pacientes de la comunidad de pacientes con HS en Colombia. Estoy muy agradecida con ustedes. Quiero contarles un poquito acerca de nuestro proyecto y lo que queremos lograr con él. De nuevo, muchas gracias. Em,
And she's
Queremos
saying that
lograr.
she's Angela Castro from Colombia. She's the youth leader of the community that was founded in 2024 in Colombia. And she has been leading all the changes and all the programs. And she will tell you a little bit about what she's going. She's very happy to receive this grant, and she's going to tell us a little bit about what they're going to do. Cuéntanos, Ángela.
Queremos facilitar la disponibilidad y entrega de medicamentos esenciales como lo es la hidrocortisona y la fluorocortisona, que en nuestro país tienden a ser negados por EPS por trámites administrativos que se transgiversan y hacen que los pacientes no reciban su medicación, que es necesaria y vital para el manejo de la condición, así como capacitar a pacientes y familias en el manejo de crisis adrenales, que también es vital.
So, she's saying that even though in Colombia the government covers the medication hydrocortisone and fluorocortisone, it is very inconsistent, and sometimes there is no medication for the community, so they are helping with that. And also education, it's a very strong, is very important for the families in Colombia, and they are also going to work on that and to get educational material. They are planning to do a web page, so it will be accessible for most of the families in Colombia.
Diseñar rutas claras para orientar a las familias en la navegación del sistema de salud.
And also, so they will make clear pathways for the families so they can understand better how the government and the health programs work in Colombia, and they can get access to their medications.
Desarrollar una plataforma educativa disponible 24/7, confiable y ajustada al lenguaje y a la realidad cultural de nuestro país.
In the web page, they will have an educational platform with our language and for our people, and so they can all have access all the time.
Co-crear junto al personal de salud material de capacitación adaptado a las necesidades de la comunidad.
We will have co-creation with the health professionals and the community of material that is adapted to their language and to their needs.
Vincular personal de salud para el desarrollo de claras procesos educativos.
Mhm. So co-create with the health professionals everything that they are going to teach to the community.
De nuevo, estoy segura de que con estos objetivos y este plan vamos a poder llegar a muchas más personas, especialmente en partes alejadas de nuestro país, zonas donde lastimosamente muchos servicios de salud no llegan y la ayuda es un poco compleja, pero estamos seguros de que con este proyecto vamos a poder estar más cerca de todos ellos.
They are very thankful and very excited of getting this grant because they know they will drive a big change, and mostly to people that are far from the big cities and have so many difficulties to get to the specialists and to get the medication and the information and the education. Congratulations, Angela.
Thank you so much to both of our grant recipients for talking and taking the time to join the meeting. And congratulations once again.
Thank you so much to the Mates for Kids grant recipients for sharing their stories. Now I'd like to introduce Dr. Evelyn Gevers.
Thank you very much. My name is Evelyn Gevers. I'm a pediatric endocrinologist specialized in endocrine disease and diabetes, and I work at Bart's Health NHS Trust in the Royal London Hospital, which is in the east part of London in the UK. And I'm the lead for type 2 diabetes and Prader-Willi syndrome, but I see many children with CAH as well and with other endocrine conditions. I'm a reader in endocrinology at a Center for Endocrinology in the William Harvey Research Institute, where we also do work on adrenal disease, including CAH. I'm here as a representative of the European Society for Pediatric Endocrinology, where I'm the chair of the science committee. And in that role, I'm a member of the scientific committee of the IFCA, and where I'm involved in assessing research applications. Okay. Can you move the slides for me?
Yeah, I'll be moving the slides for you, so
Yes, yeah,
you can
perfect.
meet.
Okay. So IFCA is the International Fund for Congenital Adrenal Hyperplasia, and they work together with ESPE, so that's the European Society for Pediatric Endocrinology, and ESE, which is the European Society for Endocrinology, so that's the Society for Adult Endocrinologists. And they together are really a joint venture to distribute worldwide the funds that IFCA has available. Next slide, please. Yes. So IFCA has been set up and is managed by parents of children with congenital adrenal hyperplasia, and it was initiated in approximately 2010. It also receives funds of the AFM Telethon, that initially was a charity to support children with neuromuscular diseases, but has grown and is now also a charity that gives funds for development of cellular and gene therapy for rare conditions. And that is why they support IFCA. So scientists and clinicians can propose projects to IFCA, and the selection of the projects then takes place by the SP-ESE IFCA Scientific Committee with representatives of SP-ESE and IFCA and experts on the panel. Next slide, please. So each year there's 250,000 euros that comes directly from the IFCA fund, and that is then topped up by another 100,000 euros that has been made available by the French AFM Telethon, specifically for cell and gene therapy. So in total there is 350,000 euros per year to support CAH research. Next slide, please. So the projects are selected based on their merit, and that's assessed by the scientific committee, which has a mix of clinicians, clinical scientists, and basic scientists from both pediatric and adult endocrinology. So it is chaired by Professor Anne Bachelot, who is an adult endocrinologist in Paris. I'm on the board, like I said, as a member and chair of the SP Science Committee. Then Andrea Shadow is the representative of the European Society of Endocrinology. It's actually not of SP, but of ESE. And he is a scientist in genetics and endocrinology. And other members of the panel are experts in adrenal disease and specifically congenital adrenal hyperplasia. That's Martine Kools from Belgium, Heidi Klaassen from the Netherlands, and Professor Stefan Bornstein from Dresden, and Dr. Pierre Val from France. Next slide, please. So over the last 15 years, really, 14 to 15 years, there were 222 projects that were proposed, and of those 222 projects, 46 have been funded. So approximately 1 in 5, 1 in 4, 1 in 5, and a total of 4.2 million euros has been funded for these projects. So a large amount of money. Next slide, please. There are 21 different countries that applied for funds. France was one of the major countries, which is not surprising since the IFCA was set up there. United States, Italy, and Australia are countries that frequently apply, but also many other countries. So in total, 21 countries, but there's still quite a lot of countries that do not apply, and indeed we would like to reach all
Rafinha,
countries
obrigada,
and
viu?
all.
Ai, não desencana, só marca aí na fichinha, tá tudo certo, tá bom?
So yeah, we would hope that we are able to reach many countries, and this meeting is also certainly helpful for that. And we hope that we reach as many countries as possible and encourage people to apply for grants. Next slide, please. And this slide shows which projects have been funded and which countries they come from. And that is mostly the United Kingdom, France and Germany, the Netherlands, United States. The countries that get funded more projects are countries that have a very strong basis in both clinical and basic science and have a very strong basis for research into adrenal disease and specifically CAH. Next slide, please. So the objectives of the IFCA are to improve treatment and care and management of children with CAH. So that includes support of children's general health that have congenital adrenal hyperplasia, but also more specifically their growth, which is affected by CAH, emergency treatment, fertility and long-term comorbidities. I haven't actually talked very much about congenital adrenal hyperplasia and what it is, and I will do that now just to introduce it to people that may not be aware what congenital adrenal hyperplasia is, because I'm aware that some people may not have a biological or medical background. So congenital adrenal hyperplasia is a congenital disorder, so a disorder that you're born with that affects the adrenals. The adrenals are glands that are near your kidneys, and they are of great importance to make hormones that really are necessary for life. So the two main hormones that they make are cortisol and mineralocorticoids. Cortisol is important to produce glucose and also to produce energy for other cells to use to be able to function normally. And when our body is in stress, for example, due to fever, infection, trauma, we make lots more cortisol. And if you're unable to do that, that may lead to your body being unable to respond to the stress and then have insufficient sugar levels, and eventually that may lead to coma, and if not treated can unfortunately lead to death. And unfortunately still children with congenital adrenal hyperplasia die because they do not get the appropriate treatment. The mineralocorticoids are hormones that are produced that are important for for stable salt concentrations, so mostly two salts, sodium and potassium. And if you don't make sufficient mineralocorticoids, you get too little sodium and too much potassium in your body, and that leads to abnormal muscle function, abnormal nerve function, abnormal brain function, so eventually also leads to your heart not being able to function normally, to keep your blood pressure at a normal maintenance, and for the brain to function normally. So if that is not treated properly, unfortunately you can also die, get seizures, your heart can give irregular beats, your blood pressure may drop, and eventually that will lead to coma and death as well. So it's extremely important that this condition is treated properly, because without proper treatment, children will become severely unwell. and it's a type of treatment that you need to take on a daily basis, multiple times per day. And if you don't take it for 24 hours, you may already become very unwell. So it's a condition that requires meticulous treatment, and then also requires has other aspects and consequences of the inability of the adrenals to function normally, and as a side effect of not being able to make the cortisol and the mineralocorticoids, you make too much male hormones instead. And both men and women and boys and girls make male hormones, but girls in much lower amounts than boys. If you make too much of the male hormones, you get abnormalities of the genitals, and that gives problems. That may give problems in sexual intercourse, but also problems with normal estrogen and testosterone production, and with fertility in the long term. So that is also a very important part of the condition that needs appropriate treatment. So therefore, the IFCA objectives are to support the health of children with CAH, their growth, their emergency treatment, and indeed their fertility and long-term comorbidities. It also promotes curative approaches, because what we do at the moment is replacing the hormones that these children are unable to make, but ideally you would like to cure the underlying problem so that no treatment is required anymore. And that is where adrenal cell and gene therapy comes in, and IFCA promotes research into adrenal cell and gene therapy therefore. Next slide, please. So this slide shows the research topics that have been funded so far. So 30% of the funding has gone into research for women with CAH, 15% for men with CAH. It's not surprising that it is more for women, because women have more additional problems in terms of genital problems and fertility problems. 33% has gone into gene therapy and 24% into other treatments for CAH. Next slide, please. So this shows some research topics that have been funded. So the top one is focuses very much on what I just mentioned. So fertility for people with CAH and pregnancy. So pregnancy is a special requires special attention in people with CAH, because of the treatment of the CAH for the pregnant lady, but at the same time also for care for the fetus that may be at risk of CAH. Other projects were to assess testicular adrenal rest tumors, and assess the long-term consequences of these rest tumors and how they should be followed up. Another project was on the long-term follow-up of the hypothalamic pituitary gonadal axis, again to assess in a different way the gonadal production, and how the regulation of gonadal production by the hypothalamus and the pituitary is affected in CAH, and what we can do to minimize those negative effects on the axis. And then another project focusing on the effect and importance of adrenaline insufficiency in CAH. Projects that were funded in terms of new treatment for congenital adrenal hyperplasia was a project of Professor Chan to inhibit ACTH with new inhibitors inhibiting the MC melanocortin receptors to reduce ACTH, in that way to assess whether that would help to decrease the increased androgen production. Another project by Professor Richard Ross to assess whether intranasal treatment is possible to use as emergency treatment in CAH. And then funding of gene and cellular therapy. And there were a couple of projects really related, both to understand the process of adrenal cell differentiation from stem cell progenitors and to use stem cells, make them committed stem cells, and then drive them to produce cortisol and aldosterone secreting cells. And then take the next step, which is a difficult step as well, to then use the right factors to take such gene therapy and stem cell therapy to the right places in our body. Next slide, please. So this shows the timeline of 15 projects that were funded into genetic and cellular therapy. So of the 46 projects that have been funded over the approximately 15 years, 15 were into genetic and cellular therapy. You can see that it's a mixture of countries, but they are countries that are very much on the forefront of development of cellular and gene therapy. So Germany, France, UK, US. Next slide, please. This shows some of the results. So this is a paper from Dr. Oikonomakos and Andrea Shadow, Charlotte Steenblok, and Yasmin Nijering, who were funded, produced in a high-impact journal, Stem Cell Reports, where the research was also pictured on the front of the journal. And this was a paper to assess indeed the production of adrenal cells from pluripotent stem cells, and they used single cell transcriptomics to assess which transcription factors were important for differentiation of cells, which pathways were involved, and then they were able to grow cells in vitro, stimulate those signaling transduction pathways and differentiation pathways, and eventually indeed were able to produce an organoid, a small clump of cells that behaves like a little adrenal and was able to respond to hormones HGH and angiotensin to produce cortisol and produce mineralocorticoids. Next slide, please. This was a clinical project, also very important, to assess adrenal rest cell tumors and assess their behavior over time, because we haven't been aware of adrenal rest cell tumors for such a long time, and this was a long-term follow-up for 10 years. And it is important because it showed that they were relatively stable over time, that men with CAH have low testosterone levels, but again that remained relatively stable over time, and that therefore you may not need to assess the adrenal rest cell tumors many times, and it may not be required to do annually, but on the other hand, it does affect fertility and inhibin B levels and sperm cells. So from that point of view, it is important to assess their size and their effect on fertility. Next slide. This shows the website of the IFCA, which has lots of information where you can see all the grants that have been funded over the years. And where you can also find information how you apply for a grant. And this slide shows the symposium that was organized in 2021 when IFCA was founded 10 years ago, was a big success. There were 360 participants from 53 different countries. So a huge success, which hopefully will be repeated at some stage in the future. Next slide, please. And then the 2025 call for proposals has been, and this shows the timeline. We had our meeting to assess projects in June. Final selection has been started in July, and I'm not 100% sure whether the winners have been announced already, but that will otherwise happen very soon. Next slide, please.
Thank you so much for your presentation, Evelyn.
Yeah, no problem.
I would now like to introduce Dr. Salwa and Dr. Esther for their presentation, and they will be sharing their screen.
Can you see me?
No, we can't see you, and we can't see your screen.
Okay. Start. Cannot open the camera, but let me share the screen. Could you hear my voice?
Yes, we can hear you.
Okay. And you can see my slide as well?
Yes.
Okay. Just a minute. So it's now clear?
Yes.
Okay, so good day, everyone. I'm Dr. Salwa Musa, pediatric endocrinologist, and I'm the ASPI CH-DSD focus group leader. And my talk will be about the update on CH research and action in Africa. And actually, it gives me a great pleasure to be here today in this session on harnessing science, technology, and innovation to address the global challenge of preventable mortality associated with childhood NCDs. And it's my great pleasure to be here today. And thank you very much for CLAM for the nice invitation to be part of this global event. And I'm here today representing ASPI CH-DSD's focus group. So in the next few minutes, I'll give a background about the CH and why it's very important, and then about the ASPI CH-DSD group and its history. Then I will move to challenges in CH service and research in Africa, and then we'll finish with update on CH research and action and the way forward. So as you all know that when we think about the global child health, infectious disease often come to mind. But in reality, childhood non-communicable disease like congenital adrenal hyperplasia is silently taking lives. And over the years, countless children die from condition where we can know how to prevent or how to treat, like congenital adrenal hyperplasia, where a simple intervention could make a very great difference between life and death. So CH is autosomal recessive disease. That means it is inherited, which lead to loss of adrenal gland ability to produce important hormones like glucocorticoids, which regulate the sugars, and the mineralocorticoids that regulate the salts, with androgen defects of various severity. It has variable presentation according to its type, making it very challenging diagnosis, and it's life-saving if diagnosed and treated early, and tragic if missed. So our efforts in this group aligns with the global agenda and UN SDGs of reducing preventable childhood mortality from non-communicable diseases. So few years back into 2022, as a part of ASPI initiative to create multiple focus group on different endocrine conditions, the ASPI CH-DSD focus group was born. And our primary objective is to make a collective response to CH in African countries and to raise awareness of congenital adrenal hyperplasia and its clinical presentation across Africa, and then to establish a regional registry to create data, and then to serve as a voice for African children with CH through advocacy, education, and professional training, and to propose context-appropriate guidelines for diagnosis and management of CH low resource setting. and to open also an effective communication channel with local, regional, and international societies. And the most important is to submit competitive research grants to unlock opportunities and secure sustainable funding for CH research. And I cannot say that we have made like a great success in the past few years due to many challenges that I will share with you. So because in God we trust, but all others must bring data. The main objective of this group is to create some situation analysis so as to address the challenges in the African countries. So we conducted 2 surveys to assess the situation of CH and to determine the challenges in diagnosis, management, and access to medicine in different African countries. And we face many challenges. There are many challenges in the Africa, but the most important ones are the poor awareness among community and even among health practitioners, and then complex social dynamics, which could lead to delayed diagnosis and even increased mortality. And also there is no neonatal screening program in Africa. There is no registry, regional or national registries, and there is no guidelines adopted to the context of the CH in African countries. We also have lack of diagnostic facilities, like, for example, hormonal testing and genetic testing, of course. And there is even the patient, if the patient diagnosed, also there is interrupted drug supply and adherence to medication is another issue. And there is less advocacy campaigns and lack of patient support groups due to many social complexity. So to unlock these challenges and to come with innovative solutions, we need to have data, and evidence usually starts with research. So the challenge in research, as I previously mentioned, there are many challenges in Africa, but the specific challenge for CH research in Africa, there is lack of registries and reliable data, for example, and also there is limited research capacity and collaboration between different African countries and also in the same country. There is a scarcity of funding opportunities, especially for this rare disease. Also, we have weak health system, information system, and poor reporting mechanism. And very few published studies despite the large clinical burden of CH across the continent. So our main mission is to build strong regional collaborative networks between different African partners and to establish a network of African researchers and clinicians focusing on CH from different African countries. And that's why the SPCH DSD focus group was created in 2022. And then we had continuous meetings and calls among partners in different African countries. And since 2022, the CH-DSD focus group have conducted 2 multi-country surveys to evaluate the burden of CH in different African countries. And also, we presented these findings at many international and regional platforms, including MP Conference, the United Nations General Assembly Science Summit 2023, ASPI Conference, and multiple community of practice meetings organized by CLA. And we held several collaborative meetings with partners and stakeholders worldwide who share the same interest in advancing CH care. And thank you for Clan and Kate for her continuous efforts in connecting us with other people. And in 2024, 3 of us, me and my colleague, Dr. Esther and Dr. Kandi from Tanzania and Dr. Esther from Uganda, have been assigned by ASPI to work on research grant proposal. And then we started to connect with many experts in the field to explore collaborative research opportunities and writing our project. And also thanks for Kate for making a lot of efforts in this area. So we found that there are many opportunities to bridge the gap in the CH research across African countries. We have to strengthen collaboration through African research networks and global partnership. We have to build capacity for sustainable research leadership in Africa, and we have to encourage local publications and capacity building to highlight the burden of the condition in Africa, and to generate basic epidemiological data like from registries or cohorts, and use available platforms to generate data that demonstrate the disease burden, like, for example, to connect with SDM registry, international registry, and to seek targeted funding by using the evidence to apply for context-specific funding and applying for rare disease research grants. So, and this could not be like, we cannot make this without global partnership. So we partner African group with other partners from other societies and centers for joint research, and to leverage mentorship, technical support, and visibility. And here I thank Prof. Cole Martin, who dedicated her knowledge and expertise in to connect with us, and through her SP visiting professorship grant, We have met last June in Tanzania, and we have worked on to develop a research proposal for CH in Africa. And also we had presented educational sessions for CH to alert the practitioners about this rare condition. So we started like three of us, me from Sudan and Dr. Esther from Uganda and Dr. Kandi from Tanzania. But we thought that we have to expand our group to contain more people from different African countries who are very committed to the CH research, and also from the countries who had very high load of CH. So now we are 6 pediatric endocrinologists who are dedicated to work on this research project. We are also thinking of expanding this group in the next few months. So we thought that we have to focus on context-relevant research priorities, and we develop a project proposal looking at the genetic etiology of CH in different African ethnic backgrounds, because we think that Africa have many diverse ethnic groups that could have different pathology of CH. And we have to develop innovative strategies in CH management and outcome in low resource setting, and to develop low-cost diagnostic pathways using clinical scores and basic biochemistry to diagnose cases like CH. And then we move to outcome research on effect of CH on growth, puberty, and psychological well-being. So why this project matters? Because we have, generate this research could be the first structural evidence based on CH etiology, management outcomes across sub-Saharan Africa. And by examining the management outcomes, this project will generate practical evidence tailored to low resource setting, and to support guideline development adopted to the African realities, and to strengthen capacity and collaboration by creating a CH registry and collaborative research network, which will build the sustainable local research capacity and foster regional partnership, and then to bridge the knowledge gap between low resource country and others, which will amplify African voices in global CH research. So the way forward is to, we need to harness innovation, work together across borders. Also together, we can transform what is currently a tragedy into a success story of resilience and survival. And we appeal for partnership, shared data, and equitable funding research opportunities to reduce preventable mortality in children with CH in Africa. So in conclusion, CH remains an under-recognized but preventable cause of morbidity and mortality among African children. And the African context presents unique challenges. Despite this, there is almost no regional data to inform practice, and the true burden of the CH in Africa remain largely unknown. So by building collaborative research network, tapping into funding opportunities, and using innovation wisely, this is the most sustainable way forward. Thank you very much.
Thank you so much, Dr. Salwa, for sharing your story with us. Now we'd like to introduce Dr. Tania Basheka.
Hi, in Brazil is good afternoon. Many thanks for this invitation, and it's a great pleasure to share our experience in CH in Brazil and to collaborate with everyone. Next slide, please. I will talk about research finds on the economic benefits of caring for children with non-communicable diseases. I use the example of congenital adrenal hyperplasia. Next, please. Congenital adrenal hyperplasia is the most common genetic cause of adrenal insufficiency during neonatal period or during childhood. The incidence in the world range from 1 to 14 and 1 to 18,000 live births. Next, please. As it is commented today, there is a spectrum of clinical manifestations including severe forms with prenatal external virilization in females and the postnatal virilization in both sexes, with the risk of salt wasting crisis in the neonatal period, until a spectrum of milder forms with late onset of hyperandrogenic manifestations. And the most severe clinical form, the salt wasting form, usually comprises 70 to 80% of cases with classical forms. Next, please. Our research started analyzing the frequency of genetic variants in patients with CH. Many years ago, we observed in Brazil and also in Mexico a lower frequency of deletions of the 21 gene. And this frequency could represent a lower frequency of this genetic variant related to the most severe clinical forms, such as related to the salt wasting phenotype. But we also was thinking maybe patients with the salt wasting form are less frequent in Brazil. So, next, please. We decided to compare that time the frequency of salt wasting form among patients from São Paulo University in the São Paulo state. The São Paulo University in Brazil probably represents the largest medical center in Brazil and maybe in Latin America. And we compared the frequency of patients with salt wasting form diagnosed through clinical means with the frequency of these patients diagnosed in the Goiás state that presented a pilot CH newborn screen. And we were surprised since salt wasting form in São Paulo, a state with a good economic development, was much lower than in the Goiás state. Approximately 60% of patients in São Paulo presented the salt wasting form. And that state with a pilot project present a good performance to diagnose the salt wasting form. Next slide, please. Since congenital adrenal hyperplasia presents autosomic recessive inheritance, we expect an equal ratio of affected females in relation to affected males. And again, we were surprised since in the São Paulo state, in our cohort, only 20% were males among the severe clinical forms. And this ratio between males and the females was normal in the Goiás state using newborn screen. So maybe the clinical diagnosis, just was commented before by Dr. Sauer, CH could represent an unrecognized disorder in São Paulo state. Next, please. So we decided to analyze the diagnosis of CH in São Paulo and the related to the diagnosis performed by clinical means. That time, our cohort with classical forms comprised almost 200 CH patients. Please, next. And we did this analysis in order to evaluate the introduction of CH newborn screen in Brazil to promote equal conditions to perform the CH diagnosis. And there is no consensus about the universal implementation of the newborn screen, and the mailing is regarding to the inconclusive data regarding the cost effectiveness of early CH diagnosis through newborn screen. Next, please. Analyzing the percentage of patients with Southwest form in another pilot program in São Paulo State of Instituto Jô Clemente. Instituto Jô Clemente is the largest newborn screen of Brazil. The frequency of Southwest patients was 90%. And we compared with the frequency of Southwest patients that belong to the historical cohort of São Paulo University of patients diagnosed through newborn screen. So we have a mortality rate of Southwest patients in the São Paulo state of approximately 20%. You can imagine that this mortality rate could be much higher in states of Brazil with lower economic development. Next, please. Extrapolating this mortality rate to the entire country in Brazil, that time before pandemic period, the number of live births in Brazil was 3 million live births per year. The incidence of CH in Brazil using that pilot program of São Paulo State and of Goiás State, the incidence of CH in both pilot programs was 1 to 10,000 live births. Extrapolating for the numbers of patients that born with CH in the entire country per year, 292 patients will born with CH per year. 19% will have the Southwest form, calculating 23% of deaths, we will have 61 deaths per year of Southwest patients in Brazil. Next, please. Precocious deaths will have an impact in the economy. In Brazil, it is estimated that each person will have 34 years of productive life. And multiplying by GDP per capita, that is approximately $90,000 per year, multiplying per number of deaths. Here, in the right side, you have the cost of precocious deaths per year in Brazil, more than $18,000 per year. This is the costs related to the absence of newborn screen in Brazil. Next, please. That's right. This is not estimate the impact in the life of these families, and does not estimate the psychological impact in these families. Additionally, other points that we analyzing, it's difficult to add or to comment now all points that we analyzed, but in the absence of a newborn screen, the diagnosis of hyponatremic dehydration in São Paulo state is very late, approximately at 38 days of life. These patients, these newborns, will present very low serum sodium levels, and this will result in severe intellectual impairment in 8% of the salt waste patients. Again, you cannot measure the impact in the quality of life of these patients, but the severe intellectual impairment also will have costs for the health public system. Next, please. The CDC of Atlanta discussed that only males should be submitted to newborn screening, since in females, the atypical genitalia could be easily identified after birth. We analyzed among our females with the salt wasting form the recognition of atypical genitalia at birth. Among 74 females, the atypical genitalia was recognized at birth in only 73% of females. And it was surprised that this recognition did not lead to the suspicion of the salt wasting form, or did not facilitate the diagnosis of the salt wasting form in most of these patients, in 67% of patients. So you can demonstrate that a typical genitalia in Brazil and the problem in other developed countries is not easily identified at birth. And when it was identified, did not facilitate the diagnosis of C8 in many of them. And 6 patients were assigned in the male sex at birth, and the 2 parents did not authorize to correct the error of sex assignment at birth. You can also, again, imagine the psychological impact of these patients reared in the male sex. Next, please. Just putting few data about this study that we published in the past. Among the salt waste patients diagnosed by clinical means, 76% were hospitalized. We calculated these costs, including the costs during the intensive care unit. We calculated the costs of follow-up of patients with severe intellectual impairment, and the cost to adapt the patients raised in the social sex. This is the costs that newborn screen could prevent, $86,000. Patients with simple virilizing form in Brazil also present a very late diagnosis in the absence of a newborn screen. These patients will present precocious, central precocious puberty, and also will need extensive therapies to improve the prediction of final height. And in the last line, you can see the costs that a newborn screen could prevent, avoiding the use of expensive therapies. Next, please. Additionally, we also analyzed in the Instituto Jô Clemente, as I said, the largest newborn screen laboratory of Brazil, the costs to diagnose salt wasting patients, including the cost to evaluate the patients with false positive results. False positive results, all diseases will present in newborn screen programs. And in this paper, we demonstrate that in Brazil, newborn screen for CH is cost effective. Next, please. CH newborn screen will introduced in the public newborn screen of Brazil. Next, please. Although this diagnostic tool is very effective to diagnose the salt wasting form, we know that there is a important prevalence, important frequency of tests with false positive results. These tests should be followed until a diagnostic conclusion, and is necessary to create reference values to reduce the probability of false positive results in order to do not overload the program and in order to avoid psychological stress for the families. Before the newborn screen introduction in Brazil, we developed reference values according to prematurity, according to birth age, and the percentage of false positive results in São Paulo state is 0.2% of the tests. Very acceptable percentage. Next, please. And to finish here, we have some data about a newborn screen, not only related to C8, but you can see that in Latin America, Cuba, Costa Rica, Chile, Uruguay, Argentina, countries with very organized newborn screen programs presented lower rates of mortality during infancy. In Brazil, we have a higher rate of infant mortality, but we have different countries in Brazil. We have states with very good economic development, and also we have states with poor economic development, result impact in health economy. Next, please. Finishing, I would like to comment now that CH newborn screens save lives and is cost effective. We worked in the Brazilian Society of Newborn Screen and since 2019, CH newborn screen was universal in Brazil. Now, it is necessary to create a data bank, and I would like to acknowledge Dr. Rodolfo Rey, that is here, when he was president of Latin American Society of Pediatric Endocrinology. He incentivate the creation of CH data bank in Latin America. Here, I would like to acknowledge my colleagues that collaborate with these studies, and I would like to congratulate ABBA for this first grant. And thank you so much, and excuses for my English.
Thank you so much, Dr. Tania. Your presentation was really great. I would now like to introduce Dr. Paula Duran. Dr. Paula, you can start your presentation. Thank you.
Okay. Thank you very much for the opportunity to be here with you and to present our work. So you can pass next slide, please. So we are going to talk about the health need assessment findings in the CAH community in Colombia. Next. So we have already talked a little bit about congenital adrenal hyperplasia, which is a lifelong chronic condition. It impacts adrenal hormone production and affects growth, puberty, fertility, and without treatment, it has a poor quality of life for people living with a CAH and can cause life-threatening adrenal crisis. So the families face great challenges with diagnosis, with treatment, and access to care. And health disparities are greater in low and middle incomes country. Next, please. So what happens in Colombia is that epidemiologic data on CAH remains scarce. So having a community-based health needs assessment provides insights that are very useful for us and to guide our actions. So thanks to CLAN and AdMates for Kids, an adapted health need assessment, which is tool CLAN has been refining and it was adapted to our country. It was applied to children and young people with CAH in their families here in Colombia. Next, please. So we did a cross-sectional survey among the CAH families. It was a structured questionnaire covering demographics, health, education, access to care. We had both quantitative and qualitative responses that were collected, and it was a community-led approach with patient and caregiver involvement. Next, please. So during a club meeting, the first club meeting where the CAH community was founded and started in 2024, we had 111 assistants between patients and family members. So there were 32 patients and their families, and the health need assessment was completed by the 32 patients. 9 were boys and 23 were girls. We have 10 children under 11 years old, 31%, of which 4 were boys and 6 were girls, and 11-year-old and older, 69%, of which 5 were boys and 17 were girls. Next, please. So I did present last year how the club meeting went and the activities we held during the club meeting. So today I'm going to focus on the results of the health need assessment that was applied during that meeting. So the majority of patients were females, 71.9%, and of the CAH subtypes, where the most frequent was salt wasting, 59.4%, and Many patients have siblings that are also affected. In our community, 36% of the children had siblings affected. Next, please. We found that mothers are most often the main caregivers, over 50%. We also have 2 families with the father, 7 families, both are mother and father, and some grandparents are also in charge of some of these kids. The parental education varies widely from primary to postgraduate, but there is a high parental concern about children's health in all of the families. And there is a big mental and emotional burden that was also reported. Next, please. Concerning the confidence in the nearby healthcare, the scale shows 1 being no confidence and 10 being very confident. As you can see, most of the families have very low or no confidence in the nearby healthcare. So that is a big issue. And concerning the academic performance of patients, most of them are doing fairly well, but we still have many families in which the performance is not as good as expected. Some report a struggle. Next, please. So in the access to healthcare, the families have to travel very long distances to get to an emergency care. The travel time to specialists can exceed 4 hours for some. And as you can see, more than half of the families take more than 2 hours to get to the pediatric endocrinologist. And the distance to most of them is more than 50 kilometers. And it's not 50 kilometers in a straight road and easy to travel. It's 50 kilometers in mountains and sometimes having to take roads in a very bad circumstance or even crossing rivers. And so it's difficult for them. Even though it is 50 kilometers, they take much more time. And the main mode of transportation is taxi or platforms, then buses. Very few go by walking and some take the motorcycle. But really the access to pediatric endocrinologists is limited by geography, because even though the distance sometimes doesn't seem too far, it is a difficult road and it's difficult to get to the big cities. Next, please. For the medications, the most common used medications in Colombia are hydrocortisone and fluorocortisone. It should be given by the government, but as you can see in the graph, the suspension of the medication is very high because the access to medication is very inconsistent and very erratic, and sometimes shortages are reported and the patients do not get their medication. Next, please. Many families report severe financial difficulties due to CAH. So in a scale from 1 to 10, 10 being severe difficulty, you can see that most of the families do experience difficulty. And this cost of the medication creates significant financial strain, and the families have to spend up to 20% of monthly income for the treatment of their child. And that is a very big financial difficulty and economic burden for the families. Next, please. As for the emergency injection, there was very low knowledge about having to use it. Only 7% were aware. Most of the family had never used it, and they don't have it at home. When they need the emergency injection, they do have to go to the emergency room or to the hospital because they don't have by the government the emergency injection at home. And as we already talked about, sometimes getting to that emergency place or getting to a hospital can be up to 4 hours, and not having that emergency injection for such a long time can cause and it can increase death. So the use of emergency corticosteroid is very rare, and there should be much more education about it in Colombia. Next, please. So the key findings we found is that the families face multi-level barriers: clinical, educational, social, and economic. There are great geographic barriers to go to specialist care, and this is critical. We do have medication shortage and high cost that limit the effective treatment for patients. There is lack of knowledge in both families and care providers around the country, mostly in the remote areas. And there is a strong community resilience despite challenges. And we have great leaders of the community that have been doing great work during this year after the community was founded. Next, please. So we detected the actions that we needed to do in our community and which ones were most important. Improve access to medication specialists is absolutely essential. We did apply another tool, another very powerful tool that CLAN has is the check score, which helps identify pretty fast the most vulnerable families. So we found that 7 of these families were living in very vulnerable situation. So we did, we called them and we had a personalized approach to each family and have been working very close with these 7 families at the same time that we work with the community. We need to strengthen the patient caregiver education, and that's why we are creating material for our country in our language, and putting it in a platform so patients can have it all the time and can understand it easily. And also we have been doing a lot of effort to educate about the emergencies and the emergency injection and how to get it. We have to address the economic barriers through policy and support programs. And we have found that community-based assessments are vital for shaping the interventions and knowing exactly what families need. And so we can focus and have some actions that are really on the target that what is needed. So this is what I wanted to talk to you about today. And thank you very much for the opportunity of presenting our work.
Thank you so much, Dr. Paula, for your amazing presentation. Now I'd like to introduce Dr. Shubha Srinivasan.
Thank you, everyone, for the opportunity to present. So I'm a paediatric endocrinologist in Sydney, Australia, and I've been working very closely with the paediatricians in Honiara, and we're going to present about how we've had to really start from the beginning to set up newborn screening in the Solomon Islands. So you can have the first slide, please. So I'll be presenting today in conjunction with Dr. Zarina Kere, who is a paediatric registrar at the National Referral Hospital in the Solomon Islands in Honiara. Slide. And this is very much a collaboration. So I'm a volunteer with Taking Paediatrics Abroad, and Dr. Catherine Currow, who is the CEO of TPA, is online as well. And we provide Zoom sessions to support the paediatricians in the Pacific Islands, including the Solomon Islands. And this is the setting up of newborn screening has been very much at the request and the drive from the paediatricians in Honiara, and we've helped to support that. We've also been working with a number of our colleagues in the NRH hospital, in antenatal wards, in labour ward, as well as the executive and the midwives, and so it's a number of people involved. And the New South Wales Newborn Screening Lab has been involved in this project. We've been supported by a grant through CLAN to develop resources. I'm very thankful for that. Slide, please. I don't need to probably tell this audience that congenital hypothyroidism is a very prevalent condition worldwide, estimated in 1 in 4,000 births. And many countries around the world now screen for congenital hypothyroidism and have done so for over 50 years in countries such as Australia and New Zealand. And if untreated from birth, it results in permanent and often severe neurodevelopmental disability and growth issues. And so it's therefore knowing that we can intervene and improve outcomes for children, it was quite confronting for us to know that there is no newborn screening for any conditions in any of the Pacific Islands. Next slide, please. As I mentioned, we've been doing newborn screening for congenital hypothyroidism in developed countries. Usually this is a dried blood spot test taken at 48 to 72 hours following birth to avoid the TSH surge that occurs in the first 24 hours after birth. And also by testing at 48 to 72 hours, we can test for other conditions as well, including CAH, as we've already heard today. Next slide, please. However, in the Solomon Islands, there is a very quick turnaround time from birth to discharge, often less than 24 hours. And most of the mothers and babies do not stay necessarily local to the hospital where they've delivered. There's a lot of moving around. There's poor telephone connections. It's difficult to contact families. And there's also very limited testing resources. So just general pathology is sent to Australia, and there's very limited resources for testing formal thyroid function tests even within the country. So we then looked to see if we could actually just start a form of newborn screening using cord blood for TSH, and this is what I'm going to present on now. Next slide. I've already talked about the TSH surge in the first 24 hours. And this is why we chose to use cord blood, because it can potentially avoid that TSH surge and we can get a result straight away. Slide. And it is also painless to the infant. It's been utilised in countries such as India for many years now, but we are aware that it cannot be used for other conditions such as CAH. So this is just the start of a newborn screening. Slide. We looked into other countries that have used cord blood TSH, including in India, Malaysia, Saudi Arabia, and looked at the various cut points that are used and the sensitivity, specificity, recall rate to determine which parameters we would use for our program in Honia. Slide, please. And we were also inspired by a program in Ontario in Canada, where dried blood spot cards have been sent from Kenya, Zambia and Bangladesh, analysing cord blood. And that was, I guess, a proof of concept that if you don't have a laboratory set up in a country with low resources, that perhaps those countries with higher resources can help to support the testing and the healthcare staff in those countries. And analysis can occur in a timely fashion, especially for TSH. Slide, please. So why the Solomon Islands? So taking paediatrics abroad, as I said, provides clinical support for paediatricians in the Pacific region, including a number of those countries that are shown on the map there. And as you can see, it's very close to Australia. And it was the paediatricians in Honiara and the Solomon Islands who asked, how can they prevent this devastating neurodevelopmental disability that they are seeing in young children with missed congenital hypothyroidism. We know from data from New Zealand that those with Pacific Islander background are twice as likely to have a positive TSH newborn screening. This is those from Pacific Islander background living in New Zealand, compared to those of European background. And so we anticipate that there is quite a high incidence of congenital hypothyroidism in the Pacific. And this is even in countries such as the Solomon Islands, where iodine is they are not iodine deficient, because there is iodine supplementation. And as I said, the local paediatricians were reporting in our clinical Zoom sessions that about 5 or 6 children per year presenting with neurodevelopmental sequelae, which could have been prevented. Slide, please. So the National Referral Hospital in Honiara is the largest hospital in the country. There are about 6,000 births per year, and we estimated that there would be 1 to 2 cases per year of congenital hypothyroidism. Slide, please. And I've already talked about the aims of the study. The main aim was to set up a cord blood screening for congenital hypothyroidism. The secondary aims to collect the incidence of congenital hypothyroidism, and then now what we're doing is building capacity for a sustainable local newborn screening program, initially with cord blood for congenital hypothyroidism, but ultimately to build up a more comprehensive newborn screening program. Slide. And we really had to start from scratch. So with taking paediatrics abroad, the next slide, we had to start with fundraising, including a fun run, which we did in Sydney to raise basic funds to get started with the program. We've been very lucky to have donations from DHL, who are couriering the newborn screening cards from Brisbane, where the samples arrived from Honiara to Brisbane with their pathology samples, and then they're now being couriered to Sydney for testing. We've had a very generous donation from Revity, who are supplying the newborn screening cards and the reagents to perform the tests for the first year, and the Clan grant, as I mentioned. And local costs are being covered through the NRH Hospital and Ministry of Health. And TPA is providing a lot of organisational support and additional cost support through charity donations. Next slide. Go to the next one. The antenatal nurses obtain consent in the clinic and provide an information sheet, which has been translated into Pidgin, as you can see. Next slide. And we've developed a flow chart of what happens once we get the results. And I won't go through a lot of details with that. It's quite standard, but as I said, we've had to start from scratch and develop a system that works for communication of results from Sydney to Honiara. Slide. And again, the next slide. Myself, Catherine Currow, and Rosie Junek, who's one of the New South Wales newborn screening nurses, visited Honiara in June this year, and did some education together with the paediatricians there about collecting cord blood, using the newborn screening cards, and storage of the cards. Slide. And this was the team here working in one of the antenatal clinics to educate the staff. Slide. But this shows what it's like in labour ward, as it is in many of the countries with low resources. There very little space and little opportunity for I guess, creating an appropriate sort of lab type space that we're used to in countries with more resources. So we really had to be creative about using the wall for storage of cards, for drying. This is the resuscitation area in the newborn, in the labour ward, just instructions for the midwives of how to collect the cord blood and appropriately label the cards so that they could be sent to Australia. Next slide. Next slide. We did have to get research ethics to start this program, both in the Solomon Islands and in Sydney, because it doesn't sort of come under general clinical care yet, but the plan is to collect the data and then it'll become general clinical care. Next slide. And then Dr. Zarina, who is online, was very much involved in a launch day in June. It was a very successful day, which was attended by the medical executive from NRH, the Ministry of Health, the local paediatricians, obstetricians, lab staff, as well as the Solomon Islands ambassador to Australia and DFAT representatives. Next slide, please. I'm going to hand over now to Dr. Zarina to just briefly talk to us about what it's like on the ground as a paediatric registrar trying to set up this program. So Zarina, if you're online, I'll let you present the next few slides.
Thank you, Professor Shuba. So we started collecting dried blood spot samples on the 13th of June, just after we did the launch here in the National Referral Hospital. And this was after a few weeks of training and doing demonstrations of how to collect, record and store the dried blood spot cards in the labor ward. Next slide, please. And since then, we have collected a total of 236 samples to the end of August. We were able to send samples for 2 babies for formal thyroid function tests, with one coming back as normal and the other one pending. Next slide, please. There are some challenges that the local team is facing with recalling patients here in the Solomon Islands. And these include difficulty in contacting families due to poor network coverage in most rural areas. And a lot of people do not have one permanent address. They travel between the islands. They come for delivery here in the capital and they travel out into the villages, and some of these would be in other islands outside of this main island. And also there are poor road conditions, unpredictable weather, and a lack of access to reliable transportation to return for follow-up and confirmatory tests. Also, recalling babies will pose a burden on the postnatal clinics. We do not have a lot of clinics that are properly staffed and they are already overwhelmed. So we do anticipate an added burden on the postnatal clinics if recall is done in the clinics outside of NRH. Next slide, please. I will hand over to Professor Shuba again to continue. Thank you.
Thanks, Zarina. I think Zarina's really highlighted the challenges faced in the Solomon Islands, and I think on reflection, a number of us have said, it would be easy to have just said, no, it's too hard. We're not going to be able to do newborn screening, but we're really keen to actually just make a start. And now that we have made a start, we're looking at the long-term goals of actually a sustainable newborn screening program and looking at the options there. As I said, currently we can't actually get formal thyroid function tests done in Honiara, and they've been sent to Brisbane, but there is a machine available now in Honiara that is being set up. So we've been looking at options of whether the cord blood could be tested there, but then obviously you need reagents and managing the formal thyroid function tests in the local laboratory there. We could continue the current arrangement with New South Wales Newborn Screening and the NRH with a service level agreement, but it also involves quite a lot of costs and the couriering and also the capacity of our lab here to take that on. So really what we're looking at is the first option there, which is having a dedicated machine in Honiara where we can do a day 2 to 3 heel prick test and also then test for other conditions long term. We could initially use this just for cord blood for TSH, and then as we build up the system of newborn screening, and as Zarina's also mentioned, a lot of this is also about education of the population, and just even the concept of newborn screening is, we're really starting from the beginning. Let's go to the next slide. And there is currently a new birthing centre being built in Honiara, and what we're really working to look at is to ensure that all babies born in the Solomon Islands will have access to newborn screening for congenital hypothyroidism and then other conditions long term, and working with the Australian government who are building the birthing centre to try and help this program to be sustainable. Slide. So in conclusion, we all know that the detection and management of congenital hypothyroidism is vital to prevent irreversible neurodevelopmental sequelae. Cord blood screening for TSH is an established method in countries with limited resources, but can also, we do need to still establish what the cutoff points are for the local population. And we need to look into sort of the future of a newborn screening program. Slide. As we've already said, but the long-term goal is building capacity for a sustainable local screening program with the Solomon Islands government and the Ministry of Health, and unlocking the potential for samples to be sent for not just Honiara, but the rest of the Solomon Islands. So this was just to highlight that we really had to start somewhere, and we're hoping that we can help the Pacific Island nations to have a sustainable program. Thank you.
Thank you so much, Professor Shuba and Dr. Thania. I would now like to introduce Dr. Aman Pulangan, who will be sharing his own slides for his presentation.
Good morning. This is my session. Let me share. Hold on. Good morning, everyone. My name is Aman Pulangan from Indonesia. I would like to share the update on Indonesia commitment to scaling newborn screening on the road to 2030. So, as you know, Indonesia is the biggest archipelago in the world. We have 17,000 islands with population right now 281 millions in 2024. And 1 year we have 4.6 births annually, and 99.5% healthcare professional believe that CH and BH provide benefit improving children's health. So this is the history of quite a long way, start from 1999 to scaling up the development of newborn screening in Indonesia. And you can see here a lot of decrease, but the coverage before is only less than 2% out of 4.6 million babies born, and the coverage during the pandemic also really low, about 2 to 3% of baby decreasing during the pandemic. But after we have a new minister from 2022, there is a massive increase. And in 2022, there is a relaunch in August 2022, and CH screening become a national program, and there is a new decree from Minister of Health. So the 2023 to 2024, CH become a national program, issued the decree minister making CH prerequisite for health workers to claim delivery rate. And CH and G6PD deficiency, congenital heart disease, hearing disease, and pilot study for 2024, and increase NBS lab. Well, the purpose is to increase the from 11 to 34, but we will see it because we have 38 provinces in Indonesia in this 17,000 island, and we have 514 county and town. So this is the coverage in 2024. So we have reached more than 2 million and 2.3 million babies in 2024 out of 4.6. So we have reached to more than 50% babies for all over these islands. And 2025, we're still working a lot until the second week of May. The coverage is only 18%, but we hope this will be increasing. We have researched the sample for CH, for CAH, and also for G6PD. But there are issues that we reagent availability. So not all laboratories have started testing for CH and G6PD screening, and 12 laboratories have conducted testing for CAH. As the week 2 May 2025, 11 laboratories have conducted testing for G6PD screening. So the challenge of newborn screening in Indonesia, this is one of our paper also. So experience of challenge with CH, newborn screening in Indonesia, and national cross-sectional study. The challenge strategy, of course, geographic and demographic diversity. We have 17,000 islands. It's a lot of geographic problem, and family refusal still have it. Lack of awareness, early discharge of newborn before, and insufficiency training of healthcare professional, resource constraint, lab infrastructure and capacity, follow-up and treatment challenge, data management and coordination, and ethical dilemma. So Indonesia as archipelago is over 17,000 islands, limited access to healthcare facility, infrastructure in remote rural area, family refusal. Most significant barriers to CH is refusal by family, about 39.2%, primarily driven by the lack of understanding regarding the importance of benefit. Early discharge, newborns are often discharged before 24 hours, preventing timely collection, especially if family do not return for follow-up testing. And 38.3% responded report early discharge. So only 38.5% of respondents received specific training for CH. with pediatric endocrinology being the only group trained. We have not very many pediatric endocrinology. We only have pediatric endocrinology in 17 provinces now out of 38 provinces. So research constraints, lab infrastructure and capacity, and 35.9% limited access to filter paper, and 17.3% reported difficulty in sending. There were only 2 labs for the whole country when MBS was initiated. And 2023, we have 11 labs now, and 2024, we have 14 labs. Target for 29 laboratory, but we are discussing right now whether increasing lab would be the solution for this, because this distribution and controlling is not easy also for after we increasing more lab. So follow-up and treatment challenge and data management and coordination. Effective follow-up and treatment require robust data management system. Challenge data collection, storage, and sharing across healthcare facility and government bodies. So our approach to the challenge: establish the urgency of newborn screening by conducting independent pilot projects demonstrating the local incidence of NBSD order, ensure the availability and access to medicine is ordered by lobbying pharmaceutical company to produce medicine locally, involvement of clinicians in development of ongoing monitoring NBS through Minister of Health Expert Committee, National Trading of Healthcare Professional by the Indonesian Pediatric Society and Indonesian Association of Clinical Pathology and Medical Laboratory, and also national campaign to increase the awareness and acceptance of newborn screening in Indonesia. So we have to travel a lot to follow up all the new lab monitoring, evaluation, visitation to the center. We see how do they recall and how the human resource work. This is not easy, because training and monitoring is also the most important thing of part of this system. So last year, we have Kathmandu Declaration, and during this meeting, we invite also our Minister of Health from Indonesia to this meeting in Nepal. So plan for 2025 to increase the coverage of baby screen, coverage up to 80,000 babies per week, add more lab to overcome the geographic challenge, and to add screening for CAH, D6PD, congenital heart disease, and also hearing screening. So lesson learned, prioritizing NBS as it gives an opportunity for every baby to live and grow healthy. Commitment and harmonious collaboration between stakeholders, overcoming technical barrier, increased number of lab, training health worker. Indonesia vast geographic location, integrating newborn screening in the healthcare system and program, increasing awareness for mothers and family to concern for screening. This is 2 examples. One from Jakarta was screened, and the other one is from center of Java, not screened. The IQ less than 90, the one on the right, and the one less than 80, and the one of, on the left, the IQ 120 something. Thank you.
Thank you so much, Dr. Ahmad, for your presentation. Now I would like to introduce Salt X from Lehigh University.
Hi again, everyone. I'm Tara, and I am the Clan UN Youth Representative, but I'm also doing research here at Lehigh University with our research project titled SALT X. These are my fellow members.
Hello, I'm Elizabeth. Thank you guys for having me, for having our team, and for listening to the work that we've been working on for this past semester into the summer and for hopefully some years coming on.
Hello, I'm Lauren Tong. I'm also one of the members of this SaltX project, and we're looking forward to continuing this on past this summer and more towards getting like a good conclusive solution or long term.
Speaking of our solution, our presentation is titled Youth-Led Research and Advocacy on the Preventable Burden of NCDs.
So our work was focused on identifying that there was a high sodium and salt intake in the Almaty region in Kazakhstan. Salt overconsumption was most prominent in Kazakhstan as the whole World Health Organization region was identified. As we all know, salt intake leads to many non-communicable diseases and symptoms related, such as stroke, obesity, increased blood pressure, cardiovascular disease, just to name a few. And there has been this dose response effect, also known as like the biological gradient, as part of the Bradford Hill criteria, that's showing that the more sodium that's present, the longer it was in your system and the longer that it took for a follow-up through the healthcare system to be notified of that overconsumption, there was worse incidence rates of that non-communicable disease. And we have seen that these effect sizes are likely underestimates due to the imprecision in measuring the salt intake, suggesting that the true risk may be even higher and that there needs to become a more comprehensive solution in measuring salt intake to better have population health outcomes.
So, like Libby just said, in Kazakhstan, they are especially at risk of CVD and other non-communicable diseases that are passed on through that can be, increased risk for because of, high sodium intake. And this especially affects vulnerable populations such as pregnant people. So people who are pregnant often experience different conditions like diarrhea, hyperemesis, hemorrhage, other things like that, and those all reduce the sodium levels in their body. Because of this leads to like a biological mechanism that causes them to have type of like high salt food cravings. And in Kazakhstan, this especially should be monitored. So when determining how much salt or sodium you should be intaking while pregnant, the guidelines for this and like for the optimum sodium levels are not very clear because of a lot of conflicting research. Some research says that depending on whatever condition you might have, like preeclampsia, you should have more salt while pregnant. And other ones say that having more salt is actually a dangerous thing to your body. So it's still something that modern obstetrics are, trying to work through. Now in Kazakhstan, because of that excessive salt intake, when that's almost 4 times as much of the daily recommended intake, this is especially important to focus on reducing salt consumption. The intrauterine environment is very delicate, and any type of disruption to this system can, because of a high sodium diet, can lead to increased risk of hypertension. As you can see on the slide, angiotensin 2 and renin levels, those both can be suppressed, as well as an elevated antidiuretic hormone that can be elevated. And these two things, when put together, those can, increase hypertension risk in the fetus and long term, the fetus not only while, as a baby, but also long term, like as an adult, that fetus can grow to have a higher risk of having cardiovascular disease. So not only does the mother impact her own health by, consuming a high sodium diet, but this will also impact the baby and the baby's life past just being, past just being in the womb. And also there's an increased maternal organ congestion during late onset preeclampsia. This can also be caused by a high sodium diet, and that is especially threatening towards the mother and the baby.
So how are we integrating science, technology, and innovation into improving this solution? Our original goal when coming into Kazakhstan for research was just to introduce a sodium label that would highlight the sodium content being low so that we could direct consumers to choose products that would be more beneficial to their health. However, after making a lot of really powerful connections with people in Kazakhstan, we were able to meet with Kazakhstan National Agricultural Research University, also known as KazNaru, who has an agro-technological hub where they initiate cutting-edge research for Kazakhstan to test dairy products for their nutrient content. This includes a lot of things like the fat and the sodium levels, and we're in the process of setting up a specific laboratory in collaboration with a local Kazakhstan farm called Huturuk Farms to send their naturally low sodium dairy products to the Kaznaru lab to influence other dairy farmers to test their milk for sodium content. We've decided to choose this initiative to put extra attention on now that we've been back from research and we're here at Lehigh University, because one of the things that we found to be the most concerning is that on the back of their packaging labels, they wouldn't have clear-cut numbers like we do in most countries around the world that would highlight the sodium content. It wasn't just about misunderstanding it, it's just simply not having it in the first place. So if we were able to initiate this conversation for other farms all over Kazakhstan to be treated and tested for sodium content, it would help people choose better products that would be more beneficial to their health, like Libby and Lauren said. Thank you.
Thank you so much to the SaltX team for presenting. We would like to announce that the round 7 grants are now open for Mates for Kids. The website will be sent in the chat below, and you guys can also scan the barcode to access.
Thank you all for joining us at our side event at the 2025 Science Summit at the UN General Assembly 80th anniversary. Follow our social media to see what else we get up to, including promotions of our grant winners for Mates for Kids.
Thank you very much, Tara and Samia, for your great emceeing of this event, and huge thanks to our excellent speakers. I just wanted to share a couple of reflections. I think at the start we saw with IFCA the power of research in leading really groundbreaking, innovative solutions and the importance of funding to achieve that. And I guess then following on straight after that, the excellent presentation from ASPE and the perspectives from Africa, just highlighting the importance of equity and the power of really passionate healthcare professionals in driving change. And there are some exciting steps underway from Africa, and hopefully you can see their passion for really harnessing technology and science into the future. The research findings from Brazil were just outstanding, and I think that Dr. Tanya's research really highlighted that research can bring child mortality out of the shadows and stop those silent deaths from being so silent. And I'm very grateful to the research happening in Brazil to show the cost benefits and effectiveness of taking action for change. From Colombia, we heard the importance of hearing from community. Sometimes there's different types of research, and the biomedical research is important, but sometimes actually hearing from community about what they need can tailor the actions that you take. And I feel like we're seeing really profound things happening in Colombia as a result. The presentations from the Solomon Islands and Indonesia on newborn screening were just really outstanding, so exciting, and just crazy to think that we're in 2025 and we're starting newborn screening in the Solomon Islands, but we need to keep doing that. We need to keep doing that across the Asia-Pacific region. And Indonesia is truly leading the way in this field, and congratulations on what's being achieved there. The numbers are just mind-boggling. I don't think many countries can understand the scale, the archipelago right across Indonesia. Indonesia is showing that it is possible. How exciting to have young people leading the way on NCDs. Congratulations to you all and your work in Kazakhstan there. We have the fourth UN high-level meeting on NCDs happening in New York next week. So, well, the week after next, on the 25th of September. It's not far off now. Samia will be joining me there at the high-level meeting, and hopefully Samia might get to say a few words. How great to have young people so passionate about NCDs. Congratulations to everything you're all doing. I think the grants, how inspirational to hear from the recipients in Brazil and Colombia. The CAH communities of the Americas region are just going to keep driving amazing change. Thrilling to have round 7 grants open. We've now given grants, I think, to about 15 countries. I'll have to get it, and Doon would know, I'd have to get it off the top of my head. But we on our way to giving 40 grants to 40 countries by 2030. So we have to keep going, and the inspirational achievements of the teams in Colombia and Brazil will keep spurring us all on, I have no doubt. Mates for Kids will continue its commitment to improving access to essential medicines, scaling newborn screening, and strengthening CAH communities. And the work that you've all done today really demonstrates the importance of that. I think young people are going to be at the heart of everything that we do moving forward as well. And on that note, I just want to give my sincerest thanks to Tara and Samia and Doon in particular for all they do. We couldn't do this without you, so thank you. As a next step, we will be preparing a report. We have a recording of this event. We will be sharing the report draft with our speakers and just getting their confirmation that the content's okay before disseminating it. Thank you everyone for joining. This is an awkward time of the day for many countries, but everybody's stayed up late, got up early, and just really shared some inspirational stories. So thank you all very much for joining. We will be sharing the video recording and the report so that more people around the world can hear about the incredible work you're all doing. Thank you, everyone. Enjoy the rest of your evening, the rest of your day, and we look forward to seeing you at our December Community of Practice meeting. Thanks, everyone.
Thank you.
Bye.
Thank you so
Bye.
much.
Thank you.
Thanks,
Bye-bye.
everyone.